nerve lah, which is second cranial nerve. There is many causes who can cause optic neuropathy. Glaucoma is one of it. The characteristic special about glaucoma compared to other neuropathy is it is progressive. Other neuropathy like optic neuritis is also can be progressive, but they have different characteristics. Okay, you can have neuritis, you can have a lot of other that can affect your optic nerve. Okay, right. Just now somebody said about structure and functional. So once you have glaucomatous optic neuropathy, you will have structural damage that you can see on the optic nerve head. Okay, and this structural damage has to correspond with the functional damage, which is your visual field. Shwana was saying from peripheral, it's true, it starts from peripheral, not straight to the central. Okay. And someone, I think Alif lagi handsome kata IOP, usually. But IOP is not 100% a causative factors as what Alif have mentioned just now. There is other causes that can cause glaucoma, and even you have other type of glaucoma where the IOP is normal. But the characteristic, the most important characteristic is structural and functional damage. Progressiveness of optic neuropathy is there. So it still belongs to glaucoma. I'm referring to normal tension glaucoma. The most important risk factors is apa? If it's not IOP. IOP only the modifiable risk factors. Anybody? What are
Aging, Doktor.
Aging.
Yes, correct. Aging, age. Okay, nanti we'll see how it is. Okay, right, next. Alamak, kenapa lah dia suka hang kejap dia. Kena stop sharing lagi. Ini host tak mandi ni sebab hujan. So asyik kena share and unshare. Okay, now when we are talking about optic neuropathy, we are talking about this part. Nampak tak? This is your optic nerve. Okay, I know masa first year you hafal je. You have done a bit on the anatomy of this, a bit on the physiology, but not in detail. So this is your entire eye. Then this is the cut section, okay? So the cut section of our eye, we have anterior segment, which start from the cornea until the lens here. This is anterior segment. And this anterior segment is divided to anterior chamber and posterior chamber by the pupil here. So anything in front here is anterior chamber and behind it is posterior chamber. The posterior segment is the entire thing, including your retina, your optic nerve, and everything is your posterior segment. Okay, don't forget in front here you have the conjunctiva yang you nampak macam putih, tapi sebenarnya conjunctiva tu clear. Okay, and of course you have extraocular muscle here. Okay, you have lateral rectus, medial rectus and everything. Okay, so now we are going to concentrate on this. But what peculiar about glaucoma is it does not go directly. There are also changes in this anterior part that indirectly cause changes here. Nanti we'll share later on what all this about. Okay, all right. Now, what really, as what mentioned just now, is irreversible. So it is the main cause of blindness, in one of the main cause of blindness, but it is number one in those developed countries who have an old population like Japan, Europe, for example. Basically, glaucoma and age-related macular degeneration are the main cause of blindness. But in the world, cataract is still main cause of blindness because we have third world country that have many poorly managed cataract or not having a cataract extraction done. Okay, all right. So when we go to the optic nerve tadi, optic nerve head that I have mentioned, the second cranial nerve, you know that there is a lot of retinal nerve fibers goes to the big bundle of the optic nerve head just now, kan? Okay. What is the number? How many retinal nerve fiber layers that goes through that? A 2.6, B 2, C 5 million, D 1.2 million, E is 1.8 billion. Okay, anybody? Janatul, what
Is
would be
it
your answer?
D? 1.2 million, Doctor?
Yes, correct. Okay. So you just remember, nampak, you just imagine that the optic nerve ni macam satu kabel besar. Dalam kabel besar tu, kita selalu tengok kabel kat tepi jalan yang orang duk pusing-pusing tu. Dalam kabel tu ada banyak wire kecil-kecil. All these wire are carrying all the information from every part of the retina through the optic nerve, through the optic pathway sampai to the visual cortex. Okey, kat mana visual cortex ni Anas? Anas yang balik Bintulu.
Visual cortex kita
Kat mana?
dekat hospital.
Ya, ke hospital. Area mana specifically?
Area hospital, area primary visual cortex.
Yes, kita panggil apa? Anas ni pusing-pusing ni. Tak sampai Bintulu ni.
Panggil hospital lobe.
Hospital load tu besar sangat. Okay, macam you kata you from Sarawak. Sarawak tu kat mana?
Broadman area
Berapa?
17.
Yes, 17. Okay, Broadman area tu. So yang tu yang dia akan interpret what you see. So if in optic neuropathy, when we are talking about glaucoma, part of this nerve fiber will die off and not functioning because you know whatever relate to the brain, you nampak tak relatedness of the eye and the brain is through the optic nerve. So whatever happened to the optic nerve, so the function of the Broadman area just now will not be functioning and patient will not be able to see. Okay? Alright, next. Aduh, asyik hang lagi. Nak dah. Siap balik. Okay. Alright. Now, what causes glaucoma really? Okay. So this is what I mentioned just now. This is like a big bundle. Ni semua ada nerve kat dalam ni. And all these small nerve ni, they are protected within the collagen here. Dia ada bundle-bundle dia tersendiri. Okay. Alright. Say, kalau you nak imagine, you just imagine that the anterior segment of the eye tu yang ada cornea semua-semua ni macam bulb lampu. Okay, so all this bulb lampu ni dia nak pergi ke soket, kan, nak plug in tu, dia kena ada wire ni. So this is the wire that we are talking about optic nerve just now. And then that wire tu, dalam wire tu, setiap wire tu dia ada small wire kecil-kecil. This is your nerve fibers just now. Okay, alright, boleh ingat macam tu, the analog. Okay, right. Just now we are talking about IOP, for example. Yes, many glaucoma has high IOP. Usually we thought, many years ago, we thought that the direct impact of increased pressure, sebab kita ingat mata ni macam balon for example, kalau pressure tinggi kita tekan on the end of the optic nerve, dia akan menyebabkan the fibers to die off. Tapi as we learn and as we do a lot of research, we know that it's not 100% true. Because in normal tension, for example, IOP is normal, still the nerve fibers die off. But it could be one of the theories, but nobody really knows what causes glaucoma. Okay. The other thing is, could it be because inadequate blood supply? Perhaps when you don't have adequate blood supply, that is the reason the nerve fiber die off. That is also another theory. Okay. The other thing is, of course, when you age, when you know age is the main risk factors, could just be neurodegenerative. You know, even if you do not have anything pun, if you are healthy, you know all your nerve will sort of apoptosis and die off due to aging. Okay, so could it be neurodegenerative? It could also, everybody will be saying, oxidative stress. You know about oxidative stress, right? It's just because imbalance between those protective effect of antioxidant and increased oxidant kan, oxidative stress that cause death of your retinal nerve fiber layers. And at the same time, there is a lot of family history. Not all, ada orang ni kalau parents dia ada glaucoma, likelihood anak dia akan dapat glaucoma is high. So now the postulation, could this also interplay with your genetic makeup? Okay, alright. But basically, what happened to nerve fiber layer regardless of the potential causes here is basically an acceleration of aging process. That's why aging is the most important risk factors. Okay. Alright. And glaucoma ni dia bukan maknanya, okay, glaucoma is a big entity. But what really cause progressive optic neuropathy ni macam-macam. Okay, there's many causes. Okay, in spite of the pathogenesis pun uncertain, and also at the same time, there is many types that can cause similar optic neuropathy. Okay, and it is a complex disease, meaning that when you say about complex disease, it is have many issues, not just because of genetic, there is genetic and environmental interaction. Okay, so we are talking about a complex disease. Okay, right. Now, who do I want to call? Bushra. Okay, can you describe to me? This is a sort of an illustration of the optic nerve head. Okay, this is what you see clinically in terms of optic nerve. Okay, so that is the beauty of ophthalmology because you can see part of the brain just using lights. Okay, Bushra, can you describe what you see here, Bushra? Bushra sudah lari ke? Boleh ke try? I know you all tak tengok lagi, nampak pelik sikit. Sebab fundoskopi pun tak sempat nak buat lagi. Tapi can you just try?
It is red in color.
Tak dengar Bushra? The breaking up.
Red in color.
Okay, first, okay, I akan just bagi you cara nak cakap pasal describe it. First, of course, you kena cakap pasal shape of the disc. This is the disc. Okay? Okay, this is the cup. Okay, this is the disc. Okay? So, you cakap pasal shape of the disc. It can be round, can be oval, can be elongated. Okay, dia tak ada square, dia tak ada triangle. Okay? Triangle tu pizza je. Okay? So, you cakap pasal shape. Then, you look at the margin. The margin ada dua je. Regular or irregular. Ataupun you can call defined or ill-defined margin. Okay. Lepas you cakap pasal margin, you need to talk about the colour. The colour ni, we are referring here, the area between the disc and the cup. So, dia ada tiga je colour dia. It's either pink, pale or hyperemic. Pink tu bukan pink colour macam Powerpuff Girl ataupun Hello Kitty. Dia adalah orange sebenarnya. Okay. Tapi sebab kita ni Asian, kita akan nampak more macam orange. Sebab Caucasian, dia tak ada banyak pigment, dia nampak more like pink. So bila kita cakap pink, dia adalah sebenarnya orange. When kita kata pale, maknanya dia adalah macam whitish. Okay. And hyperemic, they are more orange. Okay, that is colour. Okay. And then lepas pada tu, you kena cakap pasal vertical cup disc ratio. But for medical student, I ajar horizontal cup to disc ratio. So the cup to disc ratio ni, you letak ni as though dia adalah 10 the disc punya area. Then you kira lebih kurang the ratio of the cup. Macam let's say for this one, you could say berapa? 0.3, 0.4, 0.5. So kalau kita kata 0.3, 3/10. So 0.3 the ratio. Faham? And then you look at the vessels here. How's the vessels going into? Okay. And then you look at the area surrounding this this? Is there any pre-papillary atrophy? Is there any hemorrhage? Is there any exudates? Okay, or other abnormality. Itu adalah cara briefly how you describe your this. Okay, Bushra, boleh quickly try?
Okay, I try.
Hmm.
So the shape is oval,
Round lah.
round,
Hmm.
with regular margin.
Good. Mm-hmm.
The size,
Tak payahlah size sebab nanti tak pandai lagi. Okay, tak payah size.
Okay,
Postgrad boleh. Okay, go on.
the color I think is pink in color.
Good. Lagi.
For the ratio, I'm not sure.
Berapa you agak-agak? Macam kalau you agak-agak you pergi kedai nak belilah. Berapa you agak?
Let's see, 4/10.
So 0.4. Okay.
0.4.
Okay, lagi.
And then the area surrounding it.
Is there anything abnormal there? Nampak normal kan? Okay. First you tengok vessel juga. Vessels tu artery ke vein lebih besar?
I
Mana
think
satu artery, mana satu vein ni kat sini ni? Kalau you tengok sini.
actually the darker color.
Darker colour. And are you sure artery is darker colour? Artery bawa oxygenated ke non-oxygenated blood?
Oxygenated blood.
So oxygenated blood ni darker ke reddish?
Must be darker. Reddish.
So venous, ni is the vein. Vein has darker colour sebab dia banyak dah bawa carbon dioxide. Carbon dioxide ni dosa lah. Dia dosa hitam sikit. Kan? Okay, so yang artery ni dia more reddish sebab banyak oksigen, tak dosa lagi. Okay, so and at the same time, kalau artery ni dia kecil daripada vein sebab bila banyak dosa kena besar sikit, banyak sangat kan. So dia kena besar sikit. So ratio dia selalunya 3:2, maknanya 3 artery, 2 veins. Okay, alright. So this is for the rest a normal disc, structurally normal. So bila the structurally normal, this is your normal visual field. Nampak tak little dot ni, tat lalat ni? Tat lalat ni represent apa, Maisara?
Focal point.
Focal point pula.
Fovea.
Siapa kata fovea? Jangan-jangan pula dah. Apa dia? Tat lalat tu.
Blind spot doktor.
Ya, blind spot tu represent apa?
Represent dekat bahagian optic nerve.
Yes, blind spot ni represent ni lah, optic nerve ni. Sebab here is when all the data goes in. When all the data goes in ni, boleh ke you tengok bila all the data masuk kat tempat tu? Tak boleh kan? So that is your blind spot. And this is your normal vision field. Maknanya this is the area that you can see. Okay? So the most sensitive of course your fovea. So it cannot become blind spot but that is the most sensitive. Okay, faham? So this is your structure. This is your functional. You rasa if you see this patient, vision dia berapa? Visual acuity dia. Jazlyn, at this point, visual acuity dia berapa?
6/6.
Okay, 6 out of 6. Okay, so it's normal for this patient. Okay, you follow up this patient after 5 years. Tak mau kacau Alif handsome, kita tanya Alia Natasha. Okay, can you describe this Alia Natasha? Kita panggil dia Nurul ke Alia Natasha? Saya pun dah lupa dah.
Alia.
Yes, Alia. Okay.
I tried. So for the
Yes.
shape is round. For the margin is well defined.
Okay, good.
Then
Okay,
color pink
Good. Okay.
Up to this ratio
Mm-hmm.
is 0.6.
Good. Okay. Okay.
I think that's all.
Okay. The vessels wise ada abnormal tak? Tak ada.
No.
No, tak ada abnormality. Okay. Well done. Good try, Alia. So you can see here. Nampak tak vessels semua masuk macam ni kan? Nampak tak vessels kat sini? Dia lagi pergi. Ni adalah area nasal. This is temporal. You nampak tak dia pergi sedikit ke nasal? Nampak tak a small ni adalah capillary. Sebab ni adalah artery, ni vein kan. So ni capillary. Nampak tak dia macam masuk tip macam tu. Now you nampak tak dia daripada dia masuk macam ular macam tu, dia dah straight macam tu. Kan? If you look into this is this is the cup. The cup become bigger. Okay, let's say we kata yang ni 0.4, 0.3. Now maybe dia 0.6 macam Adia point out. But you nampak tak dia ada macam notch? Dia tak bulat macam ni. Tandanya the notch ni, maknanya area kat sini ni dah hilang. So maknanya some of the nerve fiber dekat this area dah hilang, dah mati. So that's why dia membesar. Kan I kata tadi semua nerve fibers pergi situ kan? So one of the characteristic of the vessels ni, bila dia masuk ke optic nerve ni, dia akan melekat on the nerve fibers. Sebab dia tak ada tempat nak pegang nerve vessels tu, dia kena lekatlah on the nerve fibers. Tapi bila nerve fibers tu dah die off, mati, so dia tak boleh melekat, that's why dia nampak dah straighten up sedikit. Okay. Kalau you nampak betul-betul ni, keliling nerve fibers ni, you nampak tak ada warna hitam-hitam ni? Ni dah start ada pre-papillary atrophy. Maknanya ada area yang dah macam atrophy keliling nerve ni. Okay. True enough for this patient, when dia dah ada defect kat sini, nampak tak? Dia punya visual acuity pula. Visual field dia dah jadi kecil. Tadi kan semua nampak. Sekarang ni dia dah ada thought kat sini tak nampak. Okay. Very subtle and just a bit here. Menandakan area kat sini. Okay. Iza. Iza rasa visual acuity dia berapa sekarang ni Iza? Dekat at this point of time.
Around 6/9 or 6/9 or 6/12.
Okay. Sebenarnya still 6/6. Okay. Alright. Apa kita tengok macam mana lagi. Okay. Azimah. Azimah can try this one Azimah. Describe this one. Yang ni dia berbeza sikit dengan tiga gambar ni. Ni adalah actual photo. Bukan illustrated. Illustrated maknanya ada orang lukis. Ni tak lukis. Okay.
I try. I try. Okay, for the shape, it is round.
Good.
And then the margin is well defined.
Good.
And then for the cup, this ratio, I think about 0.7 or 0.8.
Good. Okay.
The color, color.
Macam lipstick ke tak macam lipstick?
Color. Is it still?
Apa
Is
try?
it hypodermic? I don't know.
Tapi
Pink.
kata kalau kata well defined margin macam mana dia jadi hyperemic? Kalau selalunya hyperemic
Okay.
defined kan? Tak make sense kan? Okay, you rasa
Pink.
pink. Okay, lagi apa lagi?
Okay. And then ada
Apa?
dia punya vessel tu torches. I don't know.
Okay, lagi ada apa lagi you nampak?
Ada pre-papillary atrophy.
Good, okay lagi. Okay. Tu je.
Hemorrhage.
Very good. Here, there is hemorrhage. Okay, good. Well done, Azimah. Okay.
Thank you.
Alright. Betul Azimah kata still round. Pink. Okay, nampak tak colour kat sini nampak less pink as compared to here. So there is area yang dah less pink. So it's macam dah palish sikit, but not the entire area. Prepapillary atrophy pun dah jadi besar dah. Ya, nampak tak? Ini macam hitam-hitam lah, dia ada macam putih-putih sikit. Okay, nampak tak the vessels ni? Tadi kan I kata dia pergi lateral sikit. Ni lagi pergi nasal kan, lagi ke tepi. Betul tak? So this is what we call nasalization. And if you look at this capillary ni, tadi dia macam straighten, sekarang ni dia macam masuk, macam nak hilang. Maknanya lagi banyak extensive nerve fiber yang die off, mati. Okay, so sama juga dengan functional damage dia, visual field tu dah lagi banyak, dah lagi sikit. Okay, alright. Faham tak? Boleh? Semua orang boleh faham lagi ke? Alright. Azimah rasa berapa visual acuity dia sekarang?
Equity. 612.
612. Okey, tak apa. Nanti saya bagi tahu jawapan dia. Okey, next. Apa? Hazirah dah ya tadi? Ke belum?
Belum doktor.
Bagus mengaku belum. Okey, try yang ni.
Yang
Last
fourth tu
one.
doktor.
Yes.
I think the shape is round.
Around. Okay, fine.
Color is pink.
Are you sure? Look carefully. Is it still pink? Compare with this picture and this one. Is it still pink?
Or is it pale, doctor?
Yes, it's palish, pale. Yes. Okay, go on.
The margin is well defined.
Good.
And I think the cup this ratio is around 0.8 to 0.9.
Okay, good. Okay, lagi.
And then there is atrophy.
Apa atrophy? Prepapillary atrophy.
atrophy.
Okay, good. Okay, go on. Lagi?
Ada ischemic area.
Ischemic area macam mana ischemic area tu? Wah, terror ni. Saya pun tak nampak. Okay, tak apa. Well done, Zira. Okay. Alright. So, you nampak dia lagi besar kan? Nampak tak ni? Yang macam slit-slit ni. Nampak tak? Nampak tak semua orang? Baik, kata nampak. Tak nampak dia dekat dah ni.
Nampak.
Okay, this is what, remember I kata yang nerve fibers tu dia kena masuk dalam bundle yang sclera tu. Okay, ni nampak tak? Dia dah kosong dah sebab nerve fiber dah mati, so bundle tu kosong. Ni semua kita panggil lamella dot sign ataupun bionating sign. Ni lamella dot sign ni maknanya sekarang ni tak ada dah nerve fibers kat situ, dah mati habis semua. And you nampak tak the vessel ni lagi nasalized, lagi ke tepi macam hilang pun. Even the same vessels yang tadi tu dia macam masuk sini macam mana lagi, hilang dah. So this is what we call bean pot sign. Bean tu kacang, B-E-A-N, bean. Pot tu periuk lah. Dulu orang dulu masak periuk, masak kacang dalam periuk yang dalam tu. So dia kena letak sodik dia ataupun dia punya tu dekat tepi tu supaya dia hang. Kalau tidak nanti sodik dia akan hilang kat bawah. So yang sodik yang nampak hanging tu yang dipanggil bean pot sign. Okay? Okay, yang you kata tadi tu, okay, ni nampak tak dia colour macam merah, kat sini ada fibers. Whereby kat sini ada banyak fibers kan. So kat sini memang dah tak ada dah fibers tu. Ni kita panggil bearing sign, maknanya dia dah naked dah tak ada, kat sini je tinggal. Right? And the prepapillary atrophy become more prominent. Okay? So as you said, it's around 0.9 already dah cup this ratio dia. And nampak tak visual acuity dia? Visual acuity pula, visual field dia tinggal banyak ni je, kecil je. This is what we call tunnel vision. Hazirah rasa berapa vision dia sekarang? Hazirah dah lari?
Yes, doktor.
Vision dia berapa? You agak-agak lah vision dia berapa.
Is it
Berapa vision
9,
dia?
doktor?
Pardon? Berapa Hazira?
6/9?
Okay. Alright. Okay, well done. Do that. Try. So from here until here, the vision still could be 6. Sebab bila kita ambil visual acuity, kita tested apa? Central vision. Kita tak test peripheral vision. In glaucoma is when 6 vision is still not normal. With this constricted vision, the patient is already considered blind. Kalau you go and visit what are the criteria of WHO criteria for blindness, included constricted visual field. Okay. You rasa daripada sini ke sini, patient ni ada symptoms tak? Iza. Iza rasa dia ada simptom tak Iza? Dia sakit ke? Macam mana?
Tak.
Patient tak ada symptom most of the time in glaucoma, tapi ada juga yang ada symptoms. Okay, so that's why glaucoma ni is known as thief of sight. Tak ada symptoms, but steal your vision or rob your vision. Okay, right. Aduh, saya tak larat sungguh lah dengan hang ni. Dah expert dah nak. Dia kena share. Okay, alright. Okay, so this is the one that I have taught you just now. Okay, tak apa, it's just a revision to you. So this is another way of looking that. Nampak tak nasalization ni, nampak tak the lamella yang ada banyak nerve fibers tu dah jadi kosong. Okay, alright. So what do you think? Ni yang you nampak, you examine dia. Okay, the visual field pun part of examination. Okay, do you think how the patient will feel? Okay, in spite of, okay. What the patient will experience is, let's say you can see 3 people here, 1 boy and 2 girls. These are my children. Okay, the youngest is 20. He is now 26. She's 25. Okay. In normal patient with the cup disc ratio macam ni, this is what your visual field will be. Terang, nampak ada 3 orang. Okay. And then if the glaucoma patient later on, bila cup disc ratio dia jadi macam ni, the optic nerve structure changes dia macam ni, dia still nampak 3. But these 2 macam start to disappear. Only 1 very clear. Vision still 6/6 because if you tested it's still 6/6. Then when this happen, later on, bila cup disc ratio dah 0.8, now instead of looking at 3 or 3 plus plus, now he is convinced only 1 people in front of him. Only my youngest one is in front of him. Okay. How about when this one, bila dah advance macam ni, dia akan kata there is 1 person but he can see only this part, only the eye and the nose. This person like have missing half of the face. But the vision still 6/6 at this particular point of time. Okay, so this is what the patient experience. Okay, same goes many, that is why I emphasize again, it's a thief of sight. Okay, I have many patient that anak dia tak tahu ayah dia cakap apa. Basically ada satu patient ni, anak dia kata ayah dia tak ada selera makan. Banyak hari dah tak, banyak bulan dah makan nasi je. Letak lauk pun tak ambil. Then I ask the patient, dia tak diabetic? It's not. Dia kata letak banyak lauk pun tak ambil. Then I ask the patient. And then I call the patient, pakcik tak lalu makan ke? Lepas dia kata, tak, anak dia was so mean to him. Bagi dia nasi je. I kata, tak, anak bagi macam lauk semua tak pegang. Rupanya nobody realize he's very advanced like this. So dia nampak nasi je. Dia tak gerakkan kepala dia with the lauk keliling. So I kata pakcik tak nampak lauk keliling ni. Sebab pakcik nampak tanda kena gerak sikit kepala. And then I ask the children to put a plate that is not white. Sebab kalau white on white lagi dia tak nampak. So letak nasi dengan plate hijau ke, merah ke, biru ke, so that he can move his head and find the lauk. So that is how glaucoma impact the daily living of the patient. I have a patient who has not been to big family gathering macam Chinese New Year. I have a Chinese patient, dah dekat 5 years tak pernah pergi makan besar. I kata kenapa? Anak dia semua marah kenapa tak nak pergi nak makan kat rumah je. He said because Chinese kan kena pakai chopstick. So bila dia dapat constricted visual field, lagi susah dia nak precisely ambil makanan tu. So dia takut bila dia tumpahkan makanan, anak dia kata malu. So he avoid makan besar. So I said, no, you have to go, but someone have to help him of getting the dish out. Okay? So you can see how the impact of glaucoma. Betul tak? Alright? Okay. Now, tadi you dengarkan masa kita cakap tadi, seorang kata 0.6 lah, 0.7 lah. I kata no, it's not lah. So we have many ambiguity in terms of cup-teeth ratio. But with the advancement later on when you go to the clinic, you will see a machine what we call optical coherent tomography. Optical coherent tomography ni macam MRI untuk mata. Tapi dia lagi precise sebab dia boleh sort of come out with all the 10 layers of the retina here. Nampak tak all the 10 layers of the retina? In fact, dia boleh calculate the thickness of retina nerve fiber layers and will come up with more objective cup to this ratio. Okay, this is one of the machine. We have 2 machine of optical coherent tomography. Okay, remember when I said when everything goes to the optic nerve ni, dia dalam bundle kan, and each bundle tu represent all the spaces in the retina. This is how the nerve fibers being arranged in the retina in such a way like this. So this is the inferior fibers, nasal fibers, superior fibers, and this is your temporal fibers, and this is your fovea. This is what we call papillomacular bundle. Okay, and these fibers, yang paling resistant is papillomacular bundle ni. So God is so fair to us because kalau this one is the first to go, they're going to be very symptomatic to the patient. Sebab fovea is the most sensitive part of our eye, so kita tak nampak. So what the God is so nice to us, usually they goes to the peripheral visual field, inferior and superior first. So in a way, it is blessing in disguise. In another way, because it goes so slowly and progressively, the patient did not notice. That's why they come late. That's why they come with blindness. Okay, so it's both. It can be blessing in disguise and it can also be late detection. Okay, right. This is another, as I said, there's another machine. This is another machine. Okay, now tadi I kata glaucoma is a complex disease kan? Alright. Apa ya? Masa seterusnya. Irfan Aziz. Ke Irfan Aziz dah jawab ke? Saya pernah confused.
Belum jawab, Prof.
Okay. Alright, macam mana you nak bagikan type of glaucoma ni?
Dia ada primary and secondary type.
Okay, primary tu maksud dia apa?
Primary type ni maksud dia dia ada problem dekat dia punya lens.
Kita cakap pasal optic nerve, kenapa kita cakap pasal lens pula ni?
sorry, Prof. Not sure, Prof.
Not sure. Siapa nak tolong Irfan Haziq ni? Mana lagi satu Haziq, seorang lagi mana? Haziq Ikwan. Tolong Haziq
saya,
seorang
Prof.
lagi. Tak jawab lagi kan Haziq Ikwan kan?
Belum.
Okey. Boleh tak tolong?
Type of glaucoma macam Irfan Haziq beritahu tadi, primary and also secondary.
Okey, primary maksud dia apa?
Primary ni macam kita tak tahu dia punya causes. For example, congenital glaucoma.
Congenital bukan primary.
Bukan. Okay. Tak tahu
Sebab kita
sebab
tahu,
dia lah. Macam tu.
sebab kita tahu dia congenital. So kita tahu cause dia. Primary ni kita tak tahu cause. Bukan disebabkan systemic cause, bukan juga ocular causes. So that is primary. Secondary can be systemic causes, can be also ocular causes. Bila ophthalmology ni dia ada systemic causes and ocular causes. Okay, in glaucoma, there's a lot of systemic disease that also cause glaucoma. Okay, not just ocular. Okay, alright. Alamak, hang lagi. Penat dah saya nak hang ni. Stop sharing again. Alright, so this is how you can classify in a way. Satu, you tengok primary and secondary, and each of the primary secondary ni you kena divide into open angle and angle closure. Okay, so open angle ni yang nanti kita akan go on what is angle, then yang mana close, yang mana open. And from this open angle ada primary, ada secondary. So secondary can be ocular, macam lens also can cause secondary glaucoma. And at the same time macam kata rheumatoid arthritis, SLE also can cause secondary glaucoma. Primary ni kita tak tahu cause dia. Okay. Lagi satu, kita boleh bahagikan glaucoma ni according to age of onset. So kita ada yang macam tadi Aziz Ikhwan kata congenital. Congenital is another type of glaucoma. So it's primary tapi kita tahu cause dia congenital. And kita ada juga secondary congenital. Okay. Selalunya all this primary glaucoma dia begins onset dia is 40 and above. Tapi those who develop glaucoma is not in congenital, tak lahir-lahir dengan glaucoma. Tapi they develop glaucoma at the age of 3 but before 40 years old, kita panggil juvenile onset. That is in term of onset. Okay, faham? Alright, so this is type of glaucoma. So glaucoma ni banyak. Okay, in this tutorial I will just emphasize certain type of glaucoma, dia tak boleh semua. Okay, alright. Okay, now siapa kita nak panggil? Izzah dah sudah ke Izzah?
Dah, Prof.
Dah lah, suka pula saya panggil Liza. Jazlin. Jazlin belum ke?
Dah.
Dah juga. Maisarah dah. Maisarah dah ke?
Dah, tapi boleh je sekali lagi pun, Prof.
Tak apa. Saya bagi Mishalini. Mishalini, are you there?
Yes, Prof.
Okay, now you have 62-year-old man. Come to you. You are the medical officer in one of the pusat kesihatan. He complained of frequent fall. What could be the causes of his frequent fall?
Sorry, Prof. Tak dengar sangat. Could you repeat the question, Prof?
Nampak tak slide? Mishalini, can you see the slide?
Yes, I can see the slide, Prof.
So what is the cause of the frequent fall? Yes, Mishalini? In an old patient, 62 years old? Mishalini sudah lari ke? You all dengar tak, I?
Hello, Prof.
Is it clear?
Dengar, Prof. Misha kadang-kadang dia punya connection tak okay, Prof. Dia selalu kadang-kadang connection dia sekat-sekat.
Okay. Oh, memang sekat-sekat. Okay lah, kita try Nisa. Nisa Nur. Ya, boleh try?
I think bone weakness, like osteoporosis.
Good, okay. Possible lagi.
And poor vision.
Good, poor vision lagi.
Or muscle weakness.
Good, muscle weakness lagi. Dah. Lagi satu is balance lah. Usually either is aging causing imbalance or stroke, cerebrovascular accident. Okay, so what commonly happen in glaucoma patient is, ya Allah, makpulah yang begini pula. Again. Inilah yang saya tak suka Webex ni. Okay. So as what mentioned by Nisa, muscle weakness, poor weakness, CVA and poor vision. Okay, what happened in glaucoma patient is bila dia dapat constricted vision field, doesn't have any symptom, cuma dapat constricted vision field, dia akan ada problem with navigation and mobility. So usually dia tak nampak inferior field. So bila tak nampak inferior field, dia akan susah nak turun naik tangga. This is when they start to have fall. And usually when this patient, older patient have this constricted vision field, they don't want to travel. They like to stay in their house. Sebab apa? Sebab dia dah tahu dah. Okay, 4 steps, I get to my kitchen. 6 steps to the left, I get to my room. So dia rasa confident to be in that surrounding. This thing can only happen when this old patient pergi rumah anak dia, pergi KL ke, pergi Johor ke, pergi Penang ke, then anak dia akan nampak ayah dia asyik langgar meja, langgar pintu, trip over things, start macam try to hold on things. Tu baru anak dia, kalau anak yang observant lah. So then the anak baru bawa pergi jumpa ophthalmologist atau jumpa doktor. Then baru kita tahu dia ada very constricted vision field. So this is one of the common symptoms. They don't have pain. They have, as I said, vision is 6/6, but the only thing is constricted vision field. So don't forget, if an elderly comes to you with frequent fall, don't forget about the cause from the vision. Okay? Not just muscle, bone, CVA, imbalance and everything. Okay, now we go to the functional changes just now. Tadi kita dah pergi structural changes, kita dah tengok what happened to the optic nerve. So when we are talking about functional, we are talking about visual field. Okay, visual field is basically an island of vision in the sea of darkness. Okay, ni macam pure, macam orang sajak sikit ya. Okay, so this is the island. This is where the area that you can see, whereby the sea here surrounding the island is the darkness area. Bila kita cakap island, island always have a peak. Just tell me any island that doesn't have a peak. Kecuali Batu Putih tu lah. Okay, Batu Putih tu is not really an island, it's just man-made island I guess. So kalau kita pergi Penang, what is the highest peak? Anybody? Kat Penang? Lapar ke dah ni? Nanti tak. Baru pukul berapa ni? What is the highest peak in Penang? Volunteer.
Bukit Bendera.
Pandai, Bukit Bendera, betul. Kalau kita pergi Hong Kong, it's the Victoria Peak. Because island
tak ada air.
Okay, so the peak ni in an island represent apa? Your fovea. So they has the highest sensitivity. Whereby your optic nerve tadi tu is like dekat dengan peak ni, dia ada satu peak ataupun dalam ada gua dalam ni yang tak nampak. And then the sensitivity of the visual field ni macam island, sensitivity dia from the peak akan menurun ke arah pantai. Pantai akan jadi less sensitive. So this is the imagination of your visual field. Okay? Alright? Okay. And then your visual field, selalu you pakai both eye kan? So bila you tengok both eye, you akan your view tu adalah horizontally 160 degree. Sebab you tak boleh nampak kat belakang. You are not like an owl. An owl pun sebab apa? Sebab kepala dia boleh pusing 360 degree. Can somebody mute there? Boleh tak? Siapa cakap banyak-banyak tu? Okay. So that binocular vision ni horizontally is 160, vertically atas bawah is 120. This is when you use both right and left eye. But if you are using your monocular vision, your vision is like this. Inferior 60, superior 70, nasal 60 and temporal around 90 to 100. Okay. Nasal tu, if you have the hidung so mancung, so your nasal will be smaller. Your nasal will be like maybe 50. So kalau hidung you penyek, tak payah buat nose job. You get better visual field. Okay, so remember this is your visual field. The same thing, this visual field also represent your confrontation test. I hope you know how to do your confrontation test, okay? So again, whatever carried by your optic nerve is the photoreceptors that goes to your bipolar cells in your retina and come to retinal ganglion cells, go to your neurons. LGBD bukan LGBT ya. This lateral geniculate body, then to your occipital cortex as we have discussed just now, okay? Alright, any question up to now? Ada tak? Tak ada. Semua dah lapar ke? Sikit lagi. Right? Now, bila you do your perimetry, okay, visual field functional, kita gunakan perimetry. Okay. Kita ada dua type perimetry. Satu static, satu kinetic. Okay. Static ni maksudnya confrontation is kinetic. The one that you do confrontation because you move the object target tu. Betul tak? And that target tu adalah merah ke putih? Yang dipakai target. Yang betul confrontation. Merah ke putih?
Merah.
Yes. Merah. Betul merah?
Putih, bro.
Okay, you bawa target tu, you gerak kan? So it is kinetic. The target size dia fix. Brightness of the target fix. Dia tak ubah-ubah. Cuma dia gerak from seeing to non-seeing. So your confrontational test is kinetic. The static, nanti you masuk klinik, you will see the static one whereby the size of the target dia akan berubah-ubah in term of size and also brightness intensity. Tapi dia akan test dekat fixed position. Maknanya dia test point kat sini, dia akan satu je kat sini, tapi dia boleh ubah size, dia boleh ubah brightness. This is what you can see in the Humphrey visual field nanti bila you masuk klinik nanti. Okay? Alright. Okay, this is what Humphrey visual field all about. Dia pakai mesin, the patient akan letak dia punya chin kat sini, the head rest kat sini, kat depan ni dia akan letak corrected lenses. Nanti kat dalam ni dia ada bulat dalam tu. Nanti kat bulat tu dia ada dah point dia di mana cahaya akan keluar dekat point tu. And ni nampak ni benda yang pegang kat sini adalah for patient to pegang. Bila dia nampak cahaya dia akan tekan. Okay, alright. Whereby this is what the visual field comes out from this machine. Yang hitam-hitam ni is area that the patient cannot see. Maknanya this patient does have constricted visual field. This is your confrontation. Okay? Alright. So, you know how to do your confrontation already. You kena tutup sama-sama mata. Then you compare your visual field with the other person that you are tested. So, you make sure your visual field betul dululah. Kalau you glaucoma patient, you dengan normal patient tak jadilah kan? Alright. Alright, that is about structural and functional. Then we go into intraocular pressure. Intraocular pressure ni is important walaupun it is only a risk factors, but it is the only modifiable risk factors, and that is the aim of our management also. So what is intraocular pressure? Siapa saya nak tanya ya? Nuraini belum lagi ke? Ke Afifah? Afifah belum? Afifah?
Ya, Prof.
Afifah belum kan?
Belum.
Okay. A, B, C, D, E. Mana true, mana satu-satu. Ada which one is true, which one is false. MCQ. A, what do you think?
A, digital pressure of the eye, true. B, pressure inside the eye, true. And then C, similar to blood pressure, false. D, constant, false because it fluctuates. And then E, affected by body position, true.
Yes, okay. Of course, it's not constant. So, actually there is a similarity of blood pressure juga sebab blood pressure ada circadian rhythm. IOP also ada circadian rhythm. The only thing is memanglah measurement dia tak sama. Takkan kalau you dapat 140/100 intraocular pressure also 140/100 tak sama, tapi both ada circadian rhythm. Okay? Alright. So how do you measure intraocular pressure? As usual dia start lagi. Hey. Alright. So this is the concept of intraocular pressure. The gold standard now is using Goldman tonometry. Yang ni tu Goldman tonometry. You will see that in the clinic. Whereby dekat muncung Goldman ni dia ada a probe macam ni. Dalam ni ada prism. These things are supposed to go and adhere to the cornea here. Bila dia pergi kat cornea tu, dia sepatutnya applanate macam applanate tu maknanya dia jadikan cornea yang sepatutnya curve macam tu, dia akan jadi flatten a bit. So the amount pressure kita letak untuk flatten dia adalah the same amount of pressure inside the eye. Okay, so you are supposed to see this semicircle. Of course kita kena stain mata dia so that you get this semicircle, and this semicircle are supposed to touching slowly. And you can move the dial here. The dial ni ada 8 ni kena kali 10. So you kena move the dial so that the dial can come to touch each other like that. What is normal pressure that you know of? Siapa yang nak tanya ni? Normal pressure. Ainul Basira. Normal pressure apa?
I think it's 10 to 22 millimeter mercury.
Okay, it depends on book. Some book kata 20, some book kata 21, some book 22. As long as you refer one of these, should be okay. Okay? 10, most book using 10. But in clinical practice, we said normal pressure is 6. Anything less than 6, we call it hypotonic. Anything more than 21 or 22, we call hypertonic. Okay? Alright. Let us kenapa lah Webex ni macam ni? Okay, let us move on. Okay. Right. Now. Okay. Siapa yang belum lagi? Siapa yang host hari ni? Mana nama dia?
Saya Prof.
Wei Hua. Okay, now. This is a 40-year-old lady with right painful red eye and reduced vision. Okay. Painful red eye. Now there is symptomatic. Remember I said it's no symptomatic, but this patient comes with painful red eye and reduced vision. What do you have in mind could be the cause of painful red eye and reduced vision? Wei Hua.
First of all, I'm thinking of the inflammation.
What kind of inflammation will that be, Wei Hua?
About the iris. For example, in the uveitis.
Okay, sure. It could be uveitis. Other than that?
How about the primary angle closure glaucoma?
Okay, other than that?
Traumatic.
Okay, possible. Lagi? Lagi satu is keratitis or cornea ulcer. Okay. Alright. Kenapa lah pula dia tak? Okay, now. I know it just move up. Okay. One, when you have painful red eye with reduced vision, these are 3 most common causes. Keratitis, which is cornea ulcer, uveitis or iritis, or acute angle closure. I did not mention glaucoma because you may have elevated intraocular pressure without glaucoma, because glaucoma, as I said, has to have a optic neuropathy, whereby you have structural and functional changes. So if you just have elevated intraocular pressure, if you manage properly, the optic neuropathy would not set in. That's why the proper term is just acute angle closure without glaucoma just yet. Because to establish glaucoma, you have to have your visual field done, your structural changes seen. Okay, So these are the three most common. So this is angle closure. I'm going to emphasize on angle closure. Okay, angle closure is when many patients have symptom if they get glaucoma. Okay, this where other associated symptoms include headache, nausea and vomiting, also halos around the light. If you look at headache, nausea and vomiting, it sounds like this patient may have increased intracranial pressure rather than increased intraocular pressure. But the only make it different is usually in acute angle closure, they have painful red eye, whereby in increased intracranial pressure, you don't have painful red eye. Okay, all right. Remember in 2014 when we have a big banjir kat Kelantan, whereby only USMKK is standing, automatically become the capital city of Kelantan because Kota Baru had been submerged. So all the aids and everybody, all the helicopter every 5 minutes will land into our Padang. Okay, so we have a call from Machang saying that they have one patient, not calling us, calling the A&E. There's one patient with increased intracranial pressure, need urgent investigation. So they flew this patient from Machang, naik helikopter, zoom sampai. And bila dia sampai dekat A&E, of course the ED doctor said, okay, CT scan start. So dia pun buat CT scan. Came out normal. ED kata, oh, CT scan is not good. Cannot delineate if there is any, soft tissue tumor. Alright, do MRI. Came out MRI, normal. Nobody really look into the eye, including intracranial pressure, kan? Headache, patient keep on vomiting. Then one of the MO said, hey, the eye looks a bit quite red. They call the ophthalmologist. So I was the ophthalmology on call. I dah tahu dah, this is acute angle closure. I said, is the patient conscious, alert, in spite of vomiting? Can you send to our eye clinic? I said, yeah, they said they send. I tengok je, I know this is acute angle closure. So we do a laser, the patient is okay. So you can see the difference. If you do not refer, you do not have, if the mind doesn't know, the eye does not see. Okay, so you must have a high index of suspicion, something like that. So the problem solved by the ophthalmologist, the patient goes back well. Okay, in acute angle closure, of course you can see red eye here. Painful red eye, of course you can see there's a lot of red eye. And this time the pressure, because it's so high, it can be even unreadable by the applanation tonometry, or it can go 70 to 80. When the IOP is so high, the cornea is not functioning, it starts to become hazy. Look here, it's become hazy. And the pupil is not well dilated, become sort of fixed and dilated, not fixed and dilated, become sort of abnormal size. But most important thing is the anterior chamber depth is actually shallow because the angle has been compromised. You can see in this one, it is normal. Nampak tak? Jauh ni. Ni is the light from the slit lamp on the cornea reflected on the iris. Then you can see the depth ni jauh. Whereby here, nampak tak? Dekat. So this is what we call angle closure. The depth here pun dekat. Okay. Alright. Now, okay, now go back. Oops. I know. Oops. Okay, now, what happened in angle closure? Okay, remember when I said just now, sometimes what happened in the anterior chamber can affect the posterior chamber, the posterior segment, the optic nerve. Okay, this is how your anterior segment looks like. This is your cornea, which is clear, and this is your anterior chamber with aqueous, a lot of aqueous there, and this is your iris, and the opening here is your pupil. This is your ciliary body that produce the aqueous, and this is your lens. So this is your anterior chamber. And this is your small area of your posterior chamber. Okay, since I said ciliary body is where the aqueous is produced, the aqueous, I suppose after production, they can flow here through the pupil, bathe around your anterior chamber here, and drain into your trabecular meshwork here. This is a normal eye, okay? So this is what happened to the eye in a physiological state, okay? So what happened in the eye who is susceptible to angle closure? Basically, Asian are more susceptible to get angle closure. Female, because they are small, petite and comel. So they tend to have an eye that is also comel. Okay, but the guys are more towards open angle, where the girls are towards angle closure. So what happened when they age? They could live with the small eye for a long time until they age, the degeneration starts. What happened when certain condition, especially with the dim light? Sebab kalau you dekat panas, mata you jadi apa? Anak mata besar, dilate ke constrict in a bright daylight?
Constrict.
Yes, constrict sebab banyak sangat light. Kalau gelap, what happen to your pupil? Constrict ke dilate? Dilate. Kalau dim, neither bright nor dark. Dia jadi semi-dilated. So usually in the daytime, semi-dilated ni pupil selalunya masa bila? Maghrib, petang-petang. Ataupun when you bangun subuh, lampu tak buka lagi, lampu tidur. So jadi semi-dilated. And why I kata masa banjir tu, sekarang ni Kelantan tengah hujan tak berhenti-henti, berapa hari dah you all tak tengok matahari?
3 hari, Prof.
Yes, masih tak tengok matahari tu, apa je dengan pupil you? Most of the time, semi-dilated kan? So when they become semi-dilated, in the susceptible eye, bila dia semi-dilated, the pupil ni bila dia semi-dilated, dia akan touch a bit on the lens, betul tak? Okay, in susceptible eye, bila dia touch on the lens, lens ni pula tiba-tiba terpush anteriorly ke depan dan dia akan tutup kat sini. Once dia tutup kat sini, ciliary body keep on producing aqueous. So aqueous ni tak boleh nak pergi mana-mana. So bila aqueous tak boleh pergi mana-mana, keep on producing, dia akan tolak iris ke depan, ke depan, ke depan until dia tolak trabecular meshwork. Dah lah aqueous dekat sini pun tak boleh drain. So this is where the aqueous become trapped and the pressure goes up. Then this will give rise to the symptom of acute angle closure. Faham? Alright? Okay, let us move on. Oops. Okay.
Prof,
Yes.
can I ask?
Boleh.
Tadi kan dalam acute angle closure glaucoma kan dia punya lens ke depan kan, Prof? So why are the reason that the lens go forward?
Okay, the lens go forward ni as I said, aging process. Bila kita age, what happen to our zonio? Dia jadi weaken. Kan? Bila zonio tu kan, lens tu zonio yang pegang. Kan? Jadi weaken, lepas tu lens pula bila you age, instead of convex, dia jadi more globular, dia jadi more bulat. Okay, so bila jadi more bulat, dia akan jadi, bila dia ke depan, benda yang ke depan bulat tu, dia akan senang melekat dekat iris. Okay, right.
Okay, Prof, thank you.
Alright, this I'm explaining of primary angle closure. Okay, sometimes you can get secondary angle closure due to the lens juga bila lens tu jadi swollen. Mungkin ada trauma ataupun dia mature sangat jadi swollen. Itu pun akan menyebabkan dia push forward juga. Okay, kita panggil pupillary block. Okay. Any questions so far on acute angle closure? Tak ada. Okay, ni just for you nice to know. Nanti you all pun cakap apalah Liza ni cakap angle. Angle ni kat mana ni? Angle ni berapa degree sebenarnya? Tak nampak, tak boleh imagine. So angle structure ni kita tak nampak dengan naked eye. Kita tak nampak dengan slit lamp. Kita kena pakai special lens and guna slit lamp juga. This is your iris root. Ni iris kat sini. Nampak tak? Ni iris semua, ni your lens, your pupil. Dekat iris roots ni, nampak tak yang hitam-hitam ni? Ini adalah your trabecular meshwork. Then you have your Schlemm canal. This is when the ankle is open. Okay, as I said just now, kita ada banyak imaging with the technology OCT. That OCT optical coherent tomography tu selain daripada tengok dekat optic nerve, dia boleh ambil juga imaging of anterior segment. So here nampak tak ni iris, this is your pupil, nampak tak faintly here is your lens, and then ni kat sini ni your sclera, ni yang dia letak arrow ni is your trabecular meshwork. This is what happened during acute angle closure. Nampak tak the iris pegang ke depan, ni is the lens. Push forward, nampak tak how your trabecular meshwork also tertutup. And nampak lens iris ni dia sort of like hugging the lens like that. Nampak? This is what really happened. This is just nice to know. Nanti kan bila I cakap you tak boleh faham pula. Okay, ada question tak acute angle closure? Okay, alright. Now, tadi kita on the acute angle closure. Okay, now we go to another type of glaucoma. This is 17 years old. Baru dekat nak ambil SPM. Mak dia datang nangis-nangis. Anak dia asyik headache, tak nampak. Lepas tu dia kata, dia kata anak dia mungkin stress SPM exam kot. So then bila kita tengok funders dia, I saja letak A, B and C. I just want to, usually I will ask you to interpret, never mind. Sebab dah tengah hari ni, dah lapar kot. So we just look into this, okay? Nampak tak? Now you can see this is sort of oval shape of the disc. Nampak tak? Ini adalah the disc and the cup ni tinggal 0.95, almost fully cup. Nampak the ekstensi putih-putih ni bukan si irregular margin, this is your pre-papillary atrophy. And you can see the vessels here really nasalized kat tepi ni. Okay. And ada ni dah hilang macam Bimport sign. Ni straightening up of the capillaries. Right and left eye. This is right and this is the left eye. Actually ni yang zoom up of this eye. So this is because the onset, masa kecil tu dia nampak elok je lahir, mata dia okay. So this is what we call juvenile onset open angle glaucoma, JOAG. Okay. I want you to give a special sort of attention to this because if you look at, you compare with a patient of 70 years old, 48 years old, their lifespan is not as long as these 17 years old. So it is your duty to be able to pick up such a case and refer accordingly because these are the young people who have a long lifespan, they have a lot more to enjoy and a lot more to rehabilitate because they are part of this economy drive of our country, whereby those who are 70 years old, alamak dah pencen dah, they have seen enough. The urgency is still there. We want to give them a good quality of life even in the older age. But in this kind of patient, you know, they want to work, they want to get married. So if you miss this and they come with like this, nothing much you can be done. So you want you to detect this type of patient early. Okay? Right. So this type of patient, you have to refer to us. We can do a surgery to try to halt the progression. Okay, basically management is just to halt the progression because it's irreversible, remember? Okay, now let us move on. Okay, this is just to save you. Okay, this is another type of glaucoma. Those two are primary, okay? The other thing you know, many diabetic patient has a lot of complications. One of the complications is also to the eye, okay? This patient come to you with bilateral reduction of vision and also painful red eye of one eye, okay? In diabetic, what can cause bilateral progressive reduced vision? Wu Ji, what are the causes of bilateral progressive reduced vision in diabetic patients?
Diabetes retinopathy.
Yes, lagi? Other than diabetic retinopathy?
Hypertensive retinopathy.
Okay, possible, but it does not do hypertensive retinopathy per se rarely caused by lateral progressive reduced vision. Apa lagi yang reduced vision is progressive? Cataract, isn't it? And of course, glaucoma. Yeah, these are the common causes. Okay, right? Okay, usually in diabetic retinopathy, what's going to happen? Bila you have proliferative, you have new vessels like this, angry new vessels. So these angry new vessels are not good vessels. They are actually just to overcome ischemia due to diabetes itself on the vessels. Okay, so these new vessels, as you know, all the new vessels are not beneficial to us. They will liberate a lot of vasoendothelial growth factors. And these vasoendothelial growth factors can go to the anterior part of the eye. This is at the posterior part. It goes to the anterior part. Where does it go? The only part in the anterior part that has a lot of blood vessels is your iris. So they goes to the iris here. Then they start to form new vessels on the iris. And these new vessels on the iris slowly will creep back to the angle that I showed the picture just now. And they will cause to close up the angle. They close up the angle, meaning that they close up the trabecular meshwork, the drainage part. So the pressure will start to go up. So this is where you call neovascular glaucoma. This is a type of secondary glaucoma. Okay? Right. Okay. So what I have highlighted today is one angle closure, which is belong to primary glaucoma, juvenile open angle glaucoma. But the most common that we see is primary open angle glaucoma. The purpose I do not put in my tutorial because I expect you to be able to see in the clinic once you are in the clinic. Other than that, under primary, we have normal tension glaucoma and also congenital glaucoma. Whereby secondary, apart from neovascular just now, we have pseudo-aspiration glaucoma, drug-induced, especially steroid. We have lens-induced, we have uveitic glaucoma, traumatic glaucoma, and also secondary to other systemic disease, which I mentioned some of SLE, rheumatoid arthritis, Marfan syndrome. This is just a list because it's a complex disease, there is many causes. Okay, the rest you can read later on your own. Okay, so how do you treat it? So basically, we have three ways of treating it. For now, we have medical treatment, laser treatment, and surgical treatment. Okay, medical treatment, we don't have many choices. So far, we have 4 bullets: beta blockers, prostaglandin analog, acetazolamide, alpha agonist. These are all topical, meaning that eye drops. We also systemic, we have acetazolamide and mannitol. These are just our bullet. But many patients love this one because it's easy to use, you're self-instill, and if you have side effect, you can just stop the drugs, change the drugs, all those kind of things. But the drawback is when you start medical treatment, who is the doctor now? You or the patient? The patient lah. When it is the patient, compliance become an issue. Okay? Right, apart from medical treatment, we have laser treatment. Remember when I said acute angle closure just now? I did laser therapy. So you just need to do laser peripheral iridotomy dekat iris ni, buka, stop sini, and the aqueous can start flow out through here, and slowly when they flow out, they can just go slowly and put the iris into the normal position again. Okay, that is one way. There's many other laser too. Okay, all right. We have Argon laser trabeculoplasty, trying to open up the angle. This is the other thing, but it's not so effective in Asian patient, for example. And of course, oh my God, cepat ni pula. All right. Of course, we have surgical therapy. Okay. Okay, surgical therapy, we have trabeculectomy, whereby they have the alternative tadi, trabecular meshwork tadi, after they keluarkan trabecular meshwork, they will go under the conjunctiva, then they go to the venous system and everything. So they bypass by doing an opening here, nampak opening kat sini ni, dia buka, and then they allow direct access, not to go through the trabeculum and shoot, direct access straight to the subconjunctiva area. Okay, alright. And the other thing is glaucoma drainage device. This is another device you masuk ke dalam mata, then the aqueous can flow and goes here back to the venous plexus again. And currently we have minimal invasive glaucoma surgery whereby we put tubes so that they can bypass the trabecular meshwork. Whereby trabeculectomy will sort of ni, bawah ni ada aqueous yang lalu, nampak tak ada macam PI ni, peripheral iridectomy. Okay, alright. So, take home message very important is we need appropriate referral. We need you to be able, at least the very least, to identify acute angle closure. Not to manage, also fine as long as you refer to us. And the most important thing, as I said, it is mostly asymptomatic. Do not rely 100% on visual acuity. Don't say that, oh, visual acuity is normal, tak payah refer. Look also for the telltale sign of glaucoma. Actually, you can help to reduce glaucoma blindness. How are you going to help? Who are you now? You are now a primary eye care for now. But once you graduated, you are secondary eye care, whereby me myself are tertiary eye caregiver. Okay? Right. So if you do your part, you may give us, send to us appropriately, you may be able to prevent blindness. Okay? Alright. How about screening? Do you need to do a massive screening? You don't really need to do massive screening. You have to do targeted screening, because if you do massive screening, the percentage of, the amount of time and the amount of resources that you have to use will be quite huge, and you just be able to detect just a small fraction. So you go targeted screening. One of the targeted screening is those more than 40 years old, those have family history, those who have high refractive power, those are diabetic, these are all high risk patients. And what you can help us out is public awareness. That is what we have World Glaucoma Week, as what we mentioned by apa tadi? Alif Ansem ke tak Ansem tak ingat dah. About that World Glaucoma Week. This is one of our way to create public awareness. So one of the slogan for the public World Glaucoma Week last time different. Now we have the world is bright, save your sight. So I hope you be part of our mission and help us to catch the thief of sight. Okay, thank you very much. Any questions? Any questions so far? Any questions before we wrap up? Semua orang pergi makan nasi dah?
Prof, I want to ask one question.
Okay, go ahead. Siapa tu?
Alif.
Alif. Lagi handsome. Lagi handsome.
Lagi. Okay, the question, when the cup disc ratio increase, is it the shrink of the disc or increase of the cup?
Okay, dia tak ada shrink of disc tadi. Dia tak ada increase the cup tadi kan. Disc tu besar. Cup tengah-tengah kan. Dia tak ada kata cup tu jadi kecil ke, atau basically disc tu yang jadi besar. Sebab disc tu kalau dia kecil maknanya nerve fiber masih banyak masuk. Tapi bila dia mati, nerve fiber tak ada, cup tu jadi lagi besar and besar. Whereby the disc size still over 10. Faham tak, Alif? Did I answer your question?
Okay.
Faham. Alright. Ada lagi? Ya. Amirul. Okay. Sebenarnya kalau you tanya I naklah buat surgery cepat. Tapi most patient tak nak. most patient will try medical dulu. So dia usually kita pun okay lah, kita bagi medical dulu. Sebab as I said, medical treatment ni compliance is the problem. So kalau dia tak compliance, IOP shoot up, nanti more damage. Sebab kita punya aim of management are to prevent progression. Tu je. Because whatever been happen before this yang dah damage tu tak boleh patah balik, irreversible kan. So kita tak nak future damage sahaja. So most patient will opt for medical dulu. Okay. Right. Okay. Anything else from the rest? Okay. Alright. Kalau tak ada, that's it from me. I'll hope to see you in the clinic later on ya. Take care. Ikut SOP ya. Jangan ada positif pula. Alright.
Bye bye.
Okay. Alright. Bye.
Thank you, Prof.
Prof, thank you.
Prof.
Thank you, Prof.
Alright.
Thank you, Prof.